My greetings from sunny Dubai. Dear colleagues, you all must have heard the expression, the show must go on. Hence, the renewed norms of learning have brought us together to the IAPD virtual. And in enlivened spirits, I, Dr. Tarun Walia, your moderator for this session, welcome you all again on the fourth day of this amazing platform. Well, it would be inadequate on my part to introduce our eminent speaker for this session, Professor Monty Duggal, who needs no introduction, and the name itself is enough for one and all in the field of pediatric dentistry. However, dear colleagues, keeping up the customary tradition, it's my profound privilege to say a preface and an introductory exordium for the doyen in pediatric dentistry and a speaker dynamite, as I would call him, for being extensively popular for his lecture during various dental meets. On a personal note, I feel honored to introduce Professor Monty, who has been a friend and astute guide over the years, man with great sense of humor, and above all, a wonderful human being. Professor Duggal is currently designated on the coveted post of Vice Dean and Faculty Research Director of the National University Center for Oral Health, Singapore. He was appointed professor and chair of child dental health at Leeds Dental Institute, where he oversaw a significant postgraduate program of international acclaim in pediatric dentistry. Among his other stellar credentials, Dr. Duggal has served in various senior positions, which include the president of the European Academy of Pediatric Dentistry. To his great credence, Professor Duggal has published over 170 research papers in international journals and is author of Restorative Techniques in Pediatric Dentistry, which has sold over 16,000 copies in 7 languages worldwide. He is also co-author of textbook on dental dermatology and has co-edited Pediatric Dentistry. Recently, he has also authored Pediatric Dentistry at Glance. Before I hand over the digital platform to Dr. Duggal, here is a quick reminder and ready reckoner of the housekeeping rules, dear participants. Q&A during the live session is available through Zoom, and I would request you to put the queries in a Q&A session box. You may also like questions that have been already asked, and according to the most liked, it will be easier for me to choose which one Professor Monty will answer live. After the live session, the participants are welcome to ask questions that were not answered in Q&A part of the lecture in the agenda section of Huwa app. I now invite Professor Monty Duggal to share with us all his pearls of knowledge as he speaks to us on the topic from pulp therapy to biological management, my journey through evidence-driven evolution of care for children. Over to Professor Monty.
Thank you very much, Tarun, for your absolutely wonderful, sterling introduction. And it's always nice to hear nice things from people you like and have worked with over the years. It's a pleasure for me to join you today from beautiful Singapore. It's late afternoon here. I know it's a bit earlier in Europe and in other places. Singapore has also been going through some difficult times with the COVID situation, but there is light at the end of the tunnel, and I hope it's the same for all of you. Again, I thank IAPD for asking me to come and speak to you on this platform. When they asked me to speak, I was wondering what is it that I would like to talk about, and in the end I decided that what I will do is I will actually go through my journey through restorative management in children. Because the question is that, I mean, now, you know, I can say I'm one of the old elephants of pediatric dentistry, and I'm on the home straight, last 10 years to go to retirement. So now I'm at a stage where I think I can give an opinion which might be valuable or not, whatever the case might be to you who are listening to me. So I thought I'll pick this occasion to start at the very beginning and take you on my personal journey. In particular, what was it through my journey, what pieces of literature and what pieces of evidence influenced me or encouraged me to change direction. Because as you know, we are restorative pediatric dentists. We work straight, we fix children's teeth. Along the way, what was it that encouraged me to think laterally and to change my clinical practice? And that's really what I want to share with you today. I think it's fair to say that the present day world is very surprising and different, and it's not what it's evolving. And this is not really a place for dinosaurs anymore. And because things have evolved so quickly or are evolving so quickly, it is up to the profession to keep up with the pace of change. Because if we don't, then people will think of us as dinosaurs. And look what happened to them. I mean, we don't want to become extinct as a profession or become any less significant than we are at the moment. So we have to adapt, change, and always take into account new things that are thrown our way. So there are lots of things which have challenged me. And one of the things which is the most recent to challenge us is this surge in research on the negative impact of general anesthesia in very young children. And studies are now coming out which are showing that when children have GA as infants, their intellectual capabilities could be affected. So there is no proof of this at the moment, but I'm just trying to give you an impression of the nature of the challenge that is posed to our clinical practice. Because as pediatric dentists, we are very reliant on general anesthesia, and this is one of the challenges that has come our way, and which I'm sure is going to gather momentum over the next few years. So the question is, what has been my personal journey? And I am going to pick a few key moments which I think are of importance. And the first one, I want to go back into time and show you this article from 1942, which was one of the first to really associate dental caries and fluoride in the drinking water. Now, some of you might think, how does that matter on this platform? Well, I hope later in my talk, I will be able to show you why I picked this particular article to start my lecture with. This was the article that showed us that when fluoride concentration in the drinking water went up, caries came down and the number of caries-free children went up. But this article showed one more thing, that when there is the concentration around 1 ppm, there the benefit of caries decline and the risk of fluorosis, they are balanced. So at around 1 ppm, there is the least risk of fluorosis and the maximum benefit for caries decline. So 1 ppm was chosen as a good compromise in this field. However, the biggest impact of fluoride did not come through water fluoridation, it came through topical use. And I very strongly encourage you to read an article published by one of the great researchers in dentistry and cariology, Professor Bob Tenkati, who was all his life worked at ACTA in Amsterdam. And this article, Fluoride Mode of Action, Once There Was an Observant Dentist, it really shows you how topical effect of fluoride happens and why it is the most important and crucial for caries decline. And if I share with you two sets of data, one is, this is from the Netherlands, caries from 1965 to 1995, and you can see that the caries here was very high, and you can see the numbers at the top are the sugar consumption in Ireland, which has not changed in the Netherlands. which has not changed over the years. But in 1970s, suddenly and inexplicably at that time, caries started to drop. And why? Because in early 1970, fluoride toothpaste were introduced into the market. And now, after 1995, caries in the Netherlands is very, very low. And the second set of data which I want to show you comes from Reykjavik in Iceland. And here again, you can see a dramatic decline in dental caries over post-1970, increase in sugar consumption in that period, which doesn't make sense, increase in soft drink consumption, which doesn't make sense because caries is declining. But what has made the caries decline despite these challenges is increase in importation of fluoridated toothpaste into Iceland. When fluoride toothpaste came into the market, dental caries came down. Now, why am I saying all this? Well, the reason is that this did something which impacts our clinical practice. What? It brought about inequality. Because the benefit of fluoride toothpaste was, well, we can say universal up to a point, but it also created a very small proportion of the population who now bear an unfair burden of disease. So this gave rise to inequality. And if you look at how this inequality is, the problem is that we did not take up this challenge as a profession. And I can now say that as an old elephant. We concentrate on our rubber dam, our pulpotomies, our white crowns, our different new aesthetic materials. But we did not take into account a very simple thing of social ecology. Because if you look at a wealthy nation like United Kingdom, this is where I worked for 28 years of my life in the north of England, Bradford and Airedale. You can see that the children in this county who were least deprived had caries levels of 0.47 DMFT, and children who are the poorest had a DMFT 8 times higher within the same population. So this inequality has created a challenge for us in that the children we tend to see now who have this proportion of dental caries and these complications from dental caries, they tend to be from these socially challenged communities. And dental caries is not the only challenge in their life. They have other social challenges, other health challenges, other family related challenges. And we are trying to do more and more aesthetic, complicated, amazing, beautiful work in this population where there are huge social issues and also compliance issues as well. So we know from research that these populations tend to be the least compliant with post-operative preventive protocols as well. And it's very obvious when you look at the data from United Kingdom that the care index as a proportion of caries in the country is very, very low and has declined over the years. So what has happened is that dentists are actually not restoring most carious teeth in young children. So the burden of untreated dental caries is pretty high in this socioeconomically challenged set of people within our developed communities. Now that brings me to the next key moment. And I want to go back again to this slide to show you this data in Britain. And following this, The next key moment came in the form of papers which are very famous, and you have all read these papers, and these set of papers questioned whether primary teeth need to be restored at all. Should you restore carious primary teeth at all? And the particular paper that really created a lot of debate was this one: the fate of carious primary teeth of children who regularly attend general dental services. And what this paper showed was that when you took a practice in a group of practices in the north of England, and you look at the dentists when they restore primary teeth and when they don't restore primary teeth, the outcome of restored primary teeth and unrestored primary teeth was exactly the same. The chances of them causing pain and infection was the same. The chances of them not causing any problems were the same. So this paper questioned whether primary teeth need any restorative intervention at all. However, conclusion was unjustified. Why was it unjustified? It was unjustified because the fillings they were comparing to no fillings, or the fillings in the primary teeth that were compared to primary teeth that were left unrestored, were fillings done without local anesthesia, using simple glass ionomers shoved into cavities with the thumb, for example, not proper restorative intervention as we know it as pediatric dentists. And they were done without any understanding of pulpal reactions to the carious process. So this treatment that was compared to no treatment was poor treatment. So obviously, the outcome of poor treatment and no treatment was the same. But the authors exceeded their remit of their findings, and they published this article with the damning conclusion that restorative dentistry in children is probably not required because the outcome. Now, this made me very sad. It was wrong conclusion. I just really despair when people make these wide-reaching conclusions from bad studies. And what happens is that these studies become very dangerous because many countries, including Ireland, they instructed the public health dentists to stop filling primary teeth. That was actually, this letter is not a fake. It's a real letter that was sent by the Chief Dental Officer of Ireland to public health dentists to say, you should not restore primary teeth in children because there is no evidence. What was the evidence? From this paper that was published that I shared with you earlier. So it is this kind of bad science, overinterpretation of results, that creates a huge issue and is an obstacle in the care of children. And that's why I always say to my researchers and people who work with me, please make conclusions sensibly. And as an example, I just am putting up on the screen the conclusion from the paper that won the Nobel Prize, in which Crick and Watson defined the double helical structure of the DNA. And look at, amazing, this paper won a Nobel Prize. They just discovered how life replicates. There can be nothing bigger than this. But look at how the conclusion is so modest. It has not escaped unnoticed that these specific pairings we have postulated immediately suggest a possible copying mechanism of the genetic material. What a humble, scientific, modest conclusion of a groundbreaking, world-changing discovery. This is the type of stuff which I think a lot of dentistry needs to learn from. In the United Kingdom, these things made headline. Dentists are not restoring primary teeth, and you can see the number of children who are admitted to hospital every year to have their teeth extracted under general anesthesia. So it causes huge obstacles in the care for children. But I'm very grateful to these articles, because these articles helped us challenge and re-look at what we do. It challenged dogmas, it challenged tradition. And for that, I'm very grateful to these authors for publishing these articles, because the profession fundamentally debated on these issues. What is the issue? Well, the issue is, we all know that this is bad. As pediatric dentists, I'm sure all of you will agree this is bad. We should not have children walking around like this. And we all agree that this is fantastic. Excellent restorative care, as we have been taught as pediatric dentists. But the question I want to ask today is, what about this? If the child's quality of life is enhanced, it looks ugly, but this child is not in any pain. They are very comfortable. They are growing well. They are going to school. They don't wake up with toothache at night. They are eating well. So is this option now available to us as pediatric dentists, which in the past we only reserved if we could not do anything else? Is this not a compromise, but could an approach such as this be a parallel approach to conventional pediatric dentistry? So the challenge I want to make today to you is, what is clinical excellence? Shiny crowns, white, beautiful zirconia everywhere in the mouth? Is that beautiful? Is that good dentistry? It is good dentistry, of course, but is that the only good dentistry? Is there another way in which some children can be rescued from these invasive, painful, sometimes life-changing treatments carried out sometimes under general anesthesia? Do we need to fix everything in a child's mouth to the standards that we learned as pediatric dentists? And to answer this question, I want to go back in time again. And our gold standard comes from this paper in 1922, where Dr. Charles Sweet published the first article in which he talks about a formocresal pulpotomy. And from then on, formocresal pulpotomy became a gold standard treatment for management of what we presume to be inflamed pulps in children. Now, we've been doing this, all of you do it. I'm not going to talk about it. It's our bread and butter. Everybody who's on the other side of this lecture knows how to do this. We're using formocresal for generations. And the idea has been that when you have a inflamed or a carious lesion close to the pulp, this pulp is inflamed, so we need to do something about the inflammation. If you look at a traumatized incisor, there our remit is different. We are now not looking at inflammation there, but only contamination. Because here the pulp is not inflamed, it's only contaminated. But here, because it's a long-standing injury, the pulp is inflamed. And what has happened with this is that we have done pulpotomies after pulpotomy after pulpotomy, millions and millions of these over the years. And I was taught that direct pulp capping should never be done in a carious primary molar. And then suddenly in 2017, a systematic review is published, which shows that the outcome of indirect pulp capping and direct pulp capping is greater than the outcome for pulpotomies for carious primary molars. Where did this come from? Suddenly, direct pulp capping with a higher, bigger, better outcome than a pulpotomy? This is out of the blue. Why? What's changed? Well, What has changed is we understand inflammation now in a different way, in a better way. And secondly, we have newer biomaterials, in particular, tricalcium silicates, MTA, biodentine, for example, many others. But these two things have fundamentally changed my clinical practice. But to really get to the bottom of it, I want to start again at the very beginning, because I promised you my journey. So for this, what is a key moment I have identified? The key moment, and I feel the one that actually put us on a wrong track from the very beginning, was this article, which was a groundbreaking article of its time. In 1970, published in the British Journal of Dental Sciences, which is now the British Dental Journal, by our very respected Dr. Pamela Hobson from Manchester. And she said, irreversible pathological change may occur in the deciduous pulp before its exposure. The presence of an exposure means the pulp is definitely irreversibly inflamed, and from there we derived that pulp capping should never be done, because the pulp is irreversibly inflamed. So we cannot do a pulp capping anymore. And the idea was that if you do a large filling when there is a marginal ridge breakdown, and marginal ridge breakdown for pediatric dentists meant pulp inflammation and a pulpotomy. So when a marginal ridge is broken down, you put a large filling, you are bound to have failure because the pulp is already inflamed in that tooth. The question is this true? Is this still true? When you have primary molars with a pulpal challenge, where marginal ridges are broken down, is marginal ridge breakdown always associated with irreversible pulpal inflammation? Are we clinging to old beliefs here? Or do we have evidence that this is not the case? So what I thought was, for the next 5 minutes, I'll revisit the marginal ridge story. Well, we know, and this is a diagram from one of my textbooks, where diagrammatically we have shown that when there is a deep cavity in a primary molar, even though the primary molar is not exposed clinically, there's just a deep proximal cavity without exposure, we presume that the insult or the bacteria have already come in and the pulp has already started to be inflamed. So by the time the pulp is totally exposed, the inflammation is widespread. And we have shown this, that when you take a deep proximal lesion, and you can see the depth, this is from one of my studies, this is the base of the cavity, it is not exposed. But when I took the same slide and stained it for bacteria, you can see the bacteria are already into the pulp, because the dentinal tubules are wide and they branch out a lot, and the bacteria get into the pulp very quickly. And we assumed that this is causing pulpal inflammation. And we have done studies to show that when there is a marginal ridge breakdown in a primary molar, the pulp is already inflamed. And I just want to share with you one slide from one of our most important studies, which shows that even when there is no pulpal exposure in a primary molar, the pulp horn already manifests inflammation in the same way as an exposed pulp. So pulpal inflammation is in advance of the base of the carious lesion. However, marginal ridge must be broken down. Once the marginal ridge is broken down, irrespective of the exposure status, the pulp is inflamed. And that is a breakdown in the marginal ridge, which we have already always accepted as a reason to do pulpal intervention in children. And the conclusion of this study was that primary teeth with large proximal carious lesions but no pulp exposure may already be indicated for pulpotomies because the pulp is inflamed. Now, what about occlusal caries? Well, if you compare occlusal caries and proximal caries of the same depth, then we have shown in this study, which was published in 2008, that when you take occlusal and proximal cavities of the same depth, the inflammation in the tooth with the proximal caries is 4 times higher. So proximal carious lesions create a lot more profound inflammation of the pulp as compared to occlusal caries of the same depth. And we have taken all this evidence over the years to believe that we need to remove inflamed pulp tissue from the primary molars and do pulpotomies, which we have dutifully done, thousands of them over my years as a clinical pediatric dentist, and restore the teeth. And we have had good outcomes. I'm not saying that pulpotomy doesn't work. Of course, it works very, very well, and it's a gold standard. And we've done lots with great degree of success. And traditionally, we have used formocresol for these with, again, a great degree of clinical success and radiographic success. So there is no doubt that formocresol has been very successful in helping us achieve what we want to achieve. But my question to you today is formocresol still relevant in modern pediatric dentistry? Well, a lot of you are aware that there was a systematic review published by the National Institute of Health in the United States, which related formaldehyde to nasopharyngeal carcinoma. And this was industrial formaldehyde, of course. It's not formaldehyde we use in clinical practice. Cresol contains formaldehyde. And whenever we are working with children, we must not dismiss this as saying, oh yeah, but this is industrial formaldehyde. Well, it might be, but I don't want it in my child's mouth because it is a carcinogen. And the question is, forget about the emotive side, the emotional side. Oh, it's a carcinogen. Because some of you might think, well, it's not a carcinogen in the doses that we use it in. So I'm advancing a scientific argument that is there any biological basis for the use of a fixative in pulp therapy? The very reason we do a pulp therapy is that there is inflammation in the pulp horn usually. And when you remove the inflamed pulp, the premise of a pulpotomy is what you leave behind should be healthy and uninflamed. So why are we putting a fixative on healthy pulpal tissue? We don't want fixative on it. All you want to do is after removing the inflamed tissue, you just want hemostasis. And for hemostasis, all we need is something non-toxic, which has no lasting effect on the pulp. And ferric sulfate has always been one of the best, 15.5% ferric sulfate, been one of the best hemostat that we use in our clinical practice for impression taking, for crown and bridge work, for soaking retraction cords in. And many studies have now shown ferric sulfate to be excellent. And the beauty of ferric sulfate is it does not have a chemical action on the pulp. All it does, and this is from my study in South Africa, where you can see that if you put ferric sulfate on a bleeding tissue, there is immediate deposition of ferric protein complexes which stop or they occlude the opening of the blood vessels and stop the bleeding immediately. And when you apply ferric sulfate on a bleeding pulp, the bleeding stops within 20 to 30 seconds. Now, the question is, I know many of us and many of you are very attached to formocresol and look for reasons to keep using it. Oh, ferric sulfate doesn't work, right? It causes internal resorption. That's all rubbish. There is no evidence to suggest that. And you can look at randomized control trials. This is a 2-year outcome published by Corinne Huth from Munich, and it shows that ferric sulfate outcomes were exactly the same as formocresol. There was no difference in a randomized control trial. And the outcomes now with newer biomaterials like MTA, for example, are even better. And if you look at the ultimate way of looking at evidence, a Cochrane review, this Cochrane review concluded there is no difference in any medicaments that we use except that there are poorer outcomes for calcium hydroxide. Therefore, the most important thing is not what medicament you use. The most important thing is the correct diagnosis of the pulp inflammation. If you leave inflamed pulp in the root canal, you will get internal resorption whether you put ferric sulfate or whether you put formocresol, because internal resorption occurs due to chronic inflammation, not because of a medicament. So if you leave chronic inflammation in the root canal, there will be differentiation of giant cells, the multinucleated giant cells, which are responsible for causing the internal resorption. It's not the ferric sulfate that causes internal resorption, but poor diagnosis that causes internal resorption. My take on this is equivalent success rates are available with known less toxic medicaments. There is no biological basis for fixation, and I don't believe that there is any role for formocresol in pediatric dentistry in the modern world. I know some of you might find my statement a little bit too aggressive, but that's exactly what I believe, and I would just not touch formocresol with a barge pole, and I haven't for 11 years in my clinical practice. Then we come to a key question, and this is where I am really now going to focus the next 15 minutes of my thoughts. What about this business of direct pulp capping and indirect pulp capping, which seem to have excellent outcomes in these cases? And the question is, when you have a deep proximal cavity, which we always associate with pulp inflammation and hence a pulpotomy, is pulpotomy always the right option in these cases where the marginal ridge is broken down? If you have a deep lesion, which is not associated with any history of pain, can we avoid pulp therapy in those cases? It might be a very deep lesion, might be almost exposed, or could be very close to exposure. You can see the red. And traditionally, we want to do a pulpotomy. Is there another approach in these cases? And I'm going to contradict my own study now, because I told you earlier, I have tried. I haven't always been successful, but I have tried in my professional life to change in response to evidence, to criticism, valid criticism, not any criticism. And in my studies, I showed over the years that when there is marginal ridge breakdown, pulp horn is already inflamed. And we've said inflammation precedes exposure. But the question you need to ask me is, yes, of course, there is inflammation, but is this inflammation reversible? Or do we take it that this inflammation is irreversible and we have to do pulp therapy for these cases? Is it reversible? And I haven't shown you in my studies that it is not reversible. All I've showed is inflammation. So what is now the most crucial aspect of our understanding? And this, I think, is the last key moment I have chosen in this talk, which is the present. What is it? The biological approach. What is the biological approach? Well, the biological approach aims to shift the metabolic balance within a dental biofilm towards pulp healing. It's not intervening to take the pulp away, but to reverse the pulpal inflammation. In practical terms, what do I mean? Well, if you have a deep lesion where there is already pulp inflammation, one of the reasons we haven't been successful in many cases of indirect pulp cappings was because our restorations are not sealed. We cannot guarantee a leak-proof seal in those cases. And if we guarantee a leak-proof coronal seal, even when there is pulp inflammation, is it possible that we can treat deep lesions with good establishment of a coronal seal and no need for pulpal intervention in these cases and invasive, aggressive treatments in young children? Well, one of the techniques that I'm not going to talk about the technique because you're all aware of it, but I'm going to talk about the principle is the Hall technique. And I can tell you now, this is a technique which filled me with dismay when it was first published. But this technique involves no caries removal, and you just take a crown with no tooth preparation and you cement it onto a tooth. Of course, the bite will be raised, but it has now been shown that the bite very quickly, within weeks, returns back to normal. Now, the question is, why is this technique so successful? Every article you pick out in the literature points to the success of the Hall technique, where the tooth is just cemented onto a deep carious lesion, a tooth with a deep carious lesion. Well, the reason is that the Hall technique is resoundingly successful because it provides you with the ultimate coronal seal. It's the ultimate and the best form of indirect pulp capping. It seals the whole area. There is no stimulus going in, and the pulp is allowed to heal. And that's all. There is no rocket science behind this. It's a simple creation of a fantastic coronal seal through the application of a preformed crown and a glass ionomer cement, which is also has some karyostatic benefit as well. And the proof of the pudding is in the eating. There are now several randomized controlled trials. One of them here, 2.5-year outcomes, and you can see that the Hall technique outcome in this randomized controlled trial carried out in a specialist hospital in Greifswald in Germany, 92%, and a significant lower outcome of a conventional restorative approach, which involved conventional fillings. So the Hall technique did much better in this randomized controlled trial. And I want to share with you very quickly the results of a series of studies that we did in Leeds. One of my PhD students who wanted to look at these two approaches, and we decided to do it with my good friend and a very good researcher in Sheffield, Professor Chris Deary, who practices only biological techniques. He doesn't believe very much in the conventional approach. In Leeds, I never believed in the biological technique, and I always only did the conventional approach. So what we did, we asked 3 questions. Does biological approach work? We going to compare the Leeds and Sheffield. What is the cost effectiveness of these 2 approaches? And what is the patient and the parent experience? Question number 1, does it work? Well, we published this in IAPD in 2017, 236 primary teeth in 4 to 9-year-old children, treatment carried out in these 2 centers, Leeds and Sheffield. Over 6 years, 95% in biological arm were, or in Sheffield, in the biological approach, were asymptomatic, and 95% in conventional approach. So both approaches over 6 years, there was no difference at all. Question number 2, what is the cost effectiveness of these two approaches? We published that paper in Carey's Research, and we did an incremental cost analysis, and we factored in every possible cost into these treatments and took the help of a health economist, and we found that it was significantly cheaper to treat a child with the biological approach than to treat a child with a conventional approach. More than double the cost when you used the conventional approach as compared to the biological approach. So the conventional approach, both approaches work really well, but the biological approach is more cost effective and cheaper. And finally, what do people think of it? Patients, mothers, parents. So what is the impact on their quality of life? Both parents were quite happy with both approaches. There was no significant difference in the two groups, and the children in the two groups were equally happy. Well, you should never say children were happy. They were equally unhappy with either approach, because children are never too happy having anything done to them, but there was no difference between the two groups at all. So in these studies, we showed that these two approaches were fine. But one thing I want to point out to you now, because I'm coming to the last 10 minutes of my presentation, what is common to all these studies and RCTs? What is common is all of them are carried out by specialists or in specialist units. To overcome this problem, there was this study called Fiction Trial, and I was fortunate enough to be associated loosely with this as well. And this Fiction Trial, which was funded by the British system, the health system, was the largest clinical trial of its type in the world. It was done in primary care by general practitioners who were specially trained for this study. And they randomized the patients into 3 groups: conventional group, biological group, and in one group where prevention alone was carried out. So in the conventional group, it was full works, local anesthetic, fillings. In the biological group was only the Hall technique and indirect pulp capping without local analgesia. And prevention alone had only intensive prevention done, but all 3 arms also had prevention. So the other 2 arms also had prevention in them as well. Some of you, and I'm sure all of you, would have read this article published recently in Journal of Dental Research. This article summarizes the Fiction Trial. And what this article shows, and what this study showed, was that there was no difference between the conventional arm and the biological arm in this study. However, the children in these 2 groups, or the 3 groups, who had at least 1 episode of pain during their journey was very high, 40% plus in these 3 arms. So although this trial showed that there was no difference between these 2 arms, one of the most disturbing findings of this trial was that 40% of children in this study had episode of pain, and 25% had an episode of infection during the follow-up period. Now that is quite depressing, because this study was done in primary care. And the problem, I think, that happened here was that the dentists were trained to practice these 3 techniques in the 3 groups, but they could not perform diagnoses because they randomized the children into the 3 arms. So this trial failed from that point of view. If it had taken a more pragmatic randomization approach throughout, maybe the outcomes would have been different, because then the dentist can make a judgment on which child would benefit most from which arm of that study. So that could be possible. So what Fiction did, you see, when you look at the Hall technique, it works really well on its own. But Here, when it was applied to a primary care setting, it didn't work as well. Why? Because this is what we call as a difference between efficacy and effectiveness. Efficacy is when something works under trial conditions. Effectiveness is under normal conditions. So this fiction trial is a typical example of how something is efficacious but could not be shown to be effective in primary care setting. Now, that's not a criticism of the trial. It was very wonderfully performed scientific study, but it has clarified the future for us. It's given us a future direction that we cannot abandon the conventional arm because there is now this headwind or this momentum towards the biological approaches. They both work very well. So if they both work very well, how should we look at it in the future? Well, both techniques work. When I say techniques, I mean both approaches work, conventional and biological. But with case selection, diagnosis, and the clinical judgment of the operator. This is where the battle is won or lost. Not the techniques or the approaches. The approaches are fine, but you must focus here. So what should be the future direction for management of children with caries in the primary dentition? Biological? Conventional? No treatment? What is my take on this? Well, firstly, I can tell you that I have written this statement not for you, but for myself. I am a conventional pediatric dentist, but we ignore evidence at our peril. We cannot sacrifice evidence on the altar of old beliefs to safeguard what we have been doing for years and years and years. I have no hesitation in changing my clinical practice. If evidence is there, I will change myself. There is a very eminent American pediatric dentist. I will not name him, but he is very well known and very respected by me and by everybody. He once said to me, we should not use the Hall technique. Why? He said, we are concealing the caries. He said to me, are we healers or are we concealers? And my answer to him is, the Hall technique provides healing through concealing. You conceal the caries, you cut off the substrate, and because of that, it heals. So it is healing through concealing. It's a bit of a sort of a light-hearted comment, but it summarizes how I view this whole debate. And just to remind you, I am a pediatric dentist, a conventional one. I wrote these textbooks which sold nearly 25,000 or so copies, lots of them. And in these textbooks, it's all conventional pediatric dentistry. But I have been forced to confront the evidence and to change my way of thinking. And just coming to the last 2 or 3 slides, the profession cannot continue to ignore high quality evidence from methodologically excellent randomized controlled trials that convincingly establish the effectiveness of scientific biological approaches, not this kind of rubbish, what I call the thumbprint fillings. No, scientific, correctly performed biological approaches. A very large number of children can be rescued from languishing on GA waiting lists and invasive, aggressive treatments at a very young age by following simple biological approaches based on irrefutable evidence. Traditionally, we adopted these approaches subconsciously if you could not do anything else. So we thought, we've done a bit of a compromise here. But what I'm saying to you today is a biological approach is not a compromise. It's a parallel treatment approach. And the evidence shows that the outcomes are as good, and in some cases even better than a conventional restorative approach. But all these studies come from specialist centers. And when this approach was applied to primary care, it was not disastrous, but pretty close. Very high number of children who did not benefit had toothache in their journey. So what is the answer? The answer is both these approaches work very well, but it is the people who apply these approaches who make correct decisions on which child will benefit from which approach. And that is the key. There is no confusion or discussion in my mind whether these approaches work or not. The only discussion in my mind is which child goes to which arm. Both work, but I have to decide as a pediatric dentist where I apply these approaches. We have all the pieces here, but we need a pediatric dentist to put them together, or at least, I should not say pediatric dentist, we should not be so inclusive or exclusive a club. Any dentist who has some advanced knowledge of children's care should be able to put these pieces together and then make the right decision for the child. But whatever decision you make, any conventional or biological approach based on correct diagnosis, I'm always very happy, as being 30 odd years as a pediatric dentist, that we make a significant contribution to children's quality of life. And through science and evidence, we will always be able to do that in the future as well. So with that, I thank you very much for your attention.
Thank you, Dr. Monty. Impressive and informative as always. I completely agree with you. Progress and improvement is impossible without change. And those who cannot change their minds cannot change anything. We definitely, pediatric dentists, need to start focusing more on biological environment of oral dental tissue as new evidence emerges. I feel your presentation was very clear to everyone, and we have few questions lined for you. To begin with, Dr. Vilmala has asked whether sodium hypochlorite pulpotomy and in comparison to ferric sulfate. So well, which one do you prefer?
I mean, you know, the thing is, I get a bit worried about, I mean, there are so many materials, right? But we have evidence from Cochrane reviews for formocresol, for ferric sulfate, for MTA. Why keep introducing new toxic materials, you know, like hypochlorite? It's a bleach, you know, hypochlorite. No need. Just stick to safe, non-toxic, biocompatible sort of materials like, say, ferric sulfate. There's no need to use hypochlorite in these cases.
Okay.
The other question is on electrosurgery. Well, again, electrosurgery has been published. There are many articles on electrosurgery, but somehow electrosurgery never does as well as other things. So even though some people I know some of my colleagues who use electrosurgery, but if you just look purely at the evidence in the literature, electrosurgery slightly underperforms as compared to other techniques like formocresol pulpotomies and ferric sulfate pulpotomies.
Okay, Professor Monty, we have another question coming from Julie. If any research has been carried out on the biological approach as provided by dental therapists, are you aware of any?
Yeah, but there's been no research done, but it should not be any different.
Correct.
See, the dental therapists are allowed to do things now. They can do crowns and all sorts. So of course, I cannot see any difference. Where there might be a difference, and I'm not saying that therapists cannot make the right decisions, but if anybody who is qualified enough to make the correct diagnosis should be able to get a good outcome, whoever it is. But it is the diagnosis, and we really need to put the right approach for the right child. If you can decide that and you are competent to decide that, then there should be no difference at all.
Okay, excellent. We have another question from Dr. Teresa. In what cases Hall techniques is contraindicated?
Well, the indications for Hall technique are when you can at least see a clear band of dentine between the base of the cavity and the pulp. So if you can see a 1 millimeter or 2 millimeter clear layer of dentine between radiographically, then uh, to tell you the truth, and sometimes, in some very small children, I don't even get to take a radiograph. I look at the cavity, the child has never had pain, but the food gets stuck or something. I sometimes have done Hall technique even without taking a radiograph. So you have to use your judgment. You've got to ask about, you've got to take a pain history, which is very, very important. And if there is no spontaneous pain, then you can, in those cases, consider doing the Hall technique as well.
Okay, Dr. Monty, I think we can take one more last question. So it's from Yu Chen. So when the KD is not directly involving the pulp, that is on radiograph, but patient shows pain, is this situation suitable for Hall technique?
Well, it depends on what pain. You see, history of pain is one of the biggest skills, and I used to always teach my postgraduates and residents this very carefully. If the pain is not, let us say the pain comes and goes with a stimulus, that's reversible pulpitis. If the pain is coming on spontaneously and the child is waking up with toothache, then of course you have to do something about the pulp in those cases. So all depends on what your diagnosis is, irreversible or reversible pulpitis.
Thank you, Dr. Monty. I think we are done with the time. I really thank you very much, Dr. Monty, for the outstanding presentation. Before I wrap up the session, I convey compliments and congratulations to IAPD Board of Directors for making it happen in a novel way during times of novel corona. Stay safe and take care. Thank you very much.
Thank you. Cheers. Best of luck, everyone.